I discuss on how to maximize the clinical benefit for patients with ALK-positive non-small cell lung cancer. And you know, this is a rare entity among non-small cell lung cancers, about 5% of lung adenocarcinomas. This rearrangement predicts the efficacy of specific inhibitors. We have several inhibitors available: Crizotinib and alectinib, ceritinib, and additional third generation ALK TKIs. But for now, we have one standard only, which is Crizotinib. It is the standard of care for first-line treatment, both in the ESMO and the NCCN guidelines. We have data comparing Crizotinib to chemotherapy in the first-line setting, clearly showing the benefit in terms of response rate and PFS. Now we are discussing on how to maximize the benefit, and we know that in ALK-positive lung cancer, brain metastases are very frequent. This is a hallmark of the disease. Up to 70% of patients will ultimately develop brain metastasis. But in those patients, the overall survival is very high. It's the median overall survival of those patients, even with brain metastasis, is about 50 months. It's far higher than what we have in the global population of patients with lung cancer. And so in those patients, the frequent clinical profile for progression is oligoprogression, and then the strategy is to treat locally the lesion that is increasing in size and continue Crizotinib. So by doing this, continuation of Crizotinib beyond progression, we can increase the duration of treatment in the first-line setting and whatever is the location of the progressive disease. So ultimately, we can maximize the benefit with Crizotinib. Obviously, at some point, the patient develops systemic progression, and we need to switch to another ALK TKI. And in the ESMO and NCCN recommendation, we have alectinib and ceritinib. And by doing a sequencing ALK TKI, you can have a combined PFS of 18 months, a median OS of 50 months, as I mentioned. So ultimately, those sequencing strategies are today our standard. Obviously, things are moving pretty quickly, and we have data, and data will be presented during this meeting with ceritinib as a first-line treatment. We also had data at the last ASCO meeting with alectinib in a Japanese population in the first-line setting. So obviously those strategies are changing, and we need to learn from results of clinical studies. What we discussed also during this symposium was the need for precision medicine at the time of diagnosis, by the identification of genomic alteration predictive of the efficacy of targeted agents, but also all along the management of patients. And for example, we know that mutation in the ALK kinase may occur in addition to the gene rearrangement, and then those mutations may predict the differential efficacy of second-generation inhibitors. So we are working on trying to have access to the sequencing of those mutations to decide what is the best second-line treatment.